aware of it. There we go. And Dr. Hadland, the floor is yours.
Fantastic. Thank you so much, John. I really appreciate that, the wonderful introduction, and it's really exciting to be here. One part that was not part of my bio just now is that I'm from British Columbia. I grew up in White Rock, and both of my parents are graduates of UBC, albeit a few decades ago. And I noticed looking here in the chat that we've got some folks from Richmond, we've got some folks from Victoria. I have family in all of those places, and my folks live in Vernon, British Columbia. So anyway, it's really exciting to be here today to talk to you all, because I just feel such a strong emotional connection to you all and the work that you do as somebody who is from there and whose heart still lives on the West Coast in many ways, even though I've been gone for a long time. I'm excited to talk to you today. My talk is entitled How Clinicians Caring for Youth Can Address the Worsening Overdose Crisis. And what I want to share with you today are some tips and tricks that I have learned as somebody who's boarded in addiction medicine, who's a pediatrician, and who works caring for youth clinically doing this work. Just a little bit about our group here at Mass General. So we are a primary care program that also provides subspecialty treatment to adolescents and young adults. And so we care for patients between the ages of about 13 and 30. So, our definition of adolescent is really quite broad. We have many patients who are 25, 26, 27, and 28 years old. And that really gives us the opportunity to make sure that as young people are struggling with substances, we're not also, imposing on them the double burden of needing to transition out of pediatric care and into adult care. And so in our clinical program, we provide addiction treatment right in our primary care clinic. And that includes treatment of things like opioids, which we'll be talking about today. So fentanyl, prescription opioids, heroin, also stimulants like cocaine and methamphetamine. And then for our younger teens who might be using cannabis or might be vaping nicotine or using alcohol, we provide treatment for those conditions as well. So that gives you a little sense of what kind of work we do here at Mass General. I have no conflicts of interest to disclose today, and want to acknowledge our funding sources from the government that have helped us to do a lot of the work that I'll be talking about today. And I want to start by opening with a story, and maybe this is a story that is similar to one that you have encountered in your own practices. I want to tell you about Zach, who is a real boy who was 17 years old. That's him with his mom, who is a wonderful woman, Laura, who's given me permission to share their story today. And Zach and his mom lived in Sacramento, California. And Zach was an incredible kid who was a 17-year-old who was, a star in his school. He had been accepted to UCLA and was planning to become a psychologist. He is somebody who was star of his high school musical, had lots of friends, really had everything going for him. And like many kids during the pandemic, he got isolated from folks and spent a lot of time at home. And during that time, he experimented with pills that he had bought, that he and a friend had bought off of social media. And Zach probably only used fewer than a handful of times, maybe only even 2 or 3, according to what his family knows about him. And the most recent time that he did it, he died of a fentanyl overdose. He inadvertently took a pill that he didn't realize had been contaminated with fentanyl, which, as many of you will know, is an opioid that's at least 50 times more potent than heroin, and is really rampant in our drug supplies throughout the United States and throughout Canada. And I know that in Vancouver, that has been a particular issue, that fentanyl is just everywhere in the drug supply. And it's really stories like Zach's that motivate me to want to do this work, because the stakes are really kind of higher than ever right now. And what I want to do today, my goals for this talk are the following 3 objectives. And I've got probably about 25 minutes worth of material, and then the rest of the time will just be discussion where you can bring your questions, and hopefully we can learn a lot from each other by talking through some of these issues. But my 3 objectives are, first of all, to highlight how the overdose crisis affects young people, to internalize our role as clinicians, policymakers, researchers, and community members in confronting this crisis. And then 3, to apply evidence-based strategies to prevent, identify, and treat addiction in young people. And so some of you may have seen these. These are the most recent data from March 2023 that are available from the Public Health Agency of Canada that demonstrate age-adjusted rates of opioid overdose across Canada, according to province. And what you can see here is that rates in British Columbia are really quite high. They're well above the national average, which in Canada is 19.3. Now, it is worth noting that the reason that British Columbia is sort of shaded here is that folded into these deaths are also stimulant deaths, which are also increasingly common in the West Coast. And so, but it's important to know that these numbers are high, and in many ways, in certain groups, worsening, again, driven by highly potent fentanyl being really just pervasive throughout the drug supply. And one thing that we're grappling with in particular here in the United States, and that is a particular problem as it pertains to young people, are counterfeit pills. And this is what Zach died of. Just to give you a sense of some of the pills that are seized here in the United States, and it's the same issue in Canada. On the left, you'll see blue pills. Those are oxycodone M30 tablets. And the top tablets here are real tablets, and the bottom two tablets are fake tablets that have been made with fentanyl, which, like oxycodone, which it's meant to mimic, is a sedating opioid. But it's illicitly manufactured, it's highly potent, and it only takes just a little bit of this cheap fentanyl, reconstitute it into a pressed pill, and you can sort of give the same sedating and pain relieving effect that an oxycodone might. But of course, this is an imperfect science, and the amount of fentanyl that's in these pills varies widely and puts young people at exceptionally high risk of overdose if they use one. This middle panel actually is meant to convey real Adderall on top, and then underneath Adderall that is made into a counterfeit pill meant to simulate Adderall that's actually been made with methamphetamine. And then the far right panel here is Xanax, or alprazolam, a benzodiazepine. And the left tablet here, the white one, is the real Xanax, and the one next to it, the yellow tablet, is the fake Xanax. And again, this one is made with, that was seized, was made with fentanyl, which is a really common counterfeit pill that we see here in the United States. And so this is really important, and why the stakes are so high when we're talking about young people, is that young people experiment with pills, unfortunately. And the extent to which young people use opioids it is quite pervasive. And this is really, as I like to tell my pediatrician colleagues, really a pediatric-onset condition. Here in the United States, if you interview all people who are in addiction treatment for opioids, 2 out of every 3 of them will tell you that the very first time that they used an opioid was before age 25. And this is opioids not for medical reasons, but opioids that they're using as part of either experimentation or to seek out the euphoric feeling. And 1 out of 3 people will tell you that the first time that they used an opioid was before age 18. So again, this is a childhood onset condition that we're talking about today. Down below, you see a figure. These are data from British Columbia. This is the BC Adolescent Health Survey, 2018 data. And there is a 2023 version of this survey that's being conducted. It may have already begun, and if not, it's coming in upcoming months that will give us new insight into what's going on in drug use among teenagers. But what you can see here is that according to by age here in 2018, you can see that we got to a point where by the end of high school, by the time teens were 17 or so, about 10% or 1 in 10 high school teens in British Columbia reported that they had used a prescription pill without a doctor's consent. And 6%, or this works out to be about 1 in 15 or so, had taken more of their own medication than was prescribed. And so I really think it's important when we think about this sort of counterfeit pill market and the fact that teens commonly misuse prescription pills, you can see that there's a propensity here to try to take pills and perhaps not understand which ones are real and which ones are fake, and therefore be sort of at really high risk in this current drug market. I do want to say that For those of you who are out practicing and might be in places where teens might be getting prescribed opioids as part of management of pain or after a dental procedure or after an orthopedic procedure, there are some identifiable risk factors for which teens who use opioids will go on to have a problem with opioids. The prevalence of a teen having an overdose or addiction during the year after they've been prescribed an opioid is about 1 in 300, which means that most teens who are prescribed opioids in a medical setting, prescribed by a doctor and dispensed by a pharmacy, most teens, or about 299 out of 300, won't go on to have a problem with that opioid. They won't go on to develop addiction. They won't go on to have an overdose. But about 1 in 300 will. And so it's really incumbent on us as clinicians to try to identify which teens might be at risk. And it's important to know that there's a few different prescription level risk factors and then a few different patient level risk factors. The prescription level risk factors include prescriptions for opioids that are for long acting opioid formulations, for high daily doses of opioids, or for durations of prescribing greater than 7 days. And so it's important to try to use short-acting formulations at the lowest effective dose for the shortest period of time necessary. There's also some patient-level risk factors that have been identified, and these include boys being potentially at higher risk than girls, older age, so older teenagers and young adults are at higher risk than younger kids. If there's a family history of any addiction, if there's a history of chronic pain with the teenager, teens who are struggling with mental health disorders, particularly if they've gone untreated. So mood and anxiety disorders, psychosis, ADHD, trauma-related conditions. And then importantly, other substance use. So teens who have misused other substances. And by the way, these other substances are most commonly cannabis, alcohol, or nicotine. Those teens are at a higher risk of misusing an opioid when it's prescribed to them and having a problem with them. So that's just an important thing for us to keep in mind as people who may be working with teens who are prescribed opioids, sort of understanding who is at risk. And just to sort of like really drive this point home before we talk about treating and managing addiction, I just want to reiterate some of the take-home points that the data really support when it comes to prescribing an opioid. We want to make sure, first of all, that we maximize non-pharmacologic approaches. So if teens can benefit from physical therapy or rest and relaxation, from ice, from stretching, those sorts of things, we want to maximize those. Teens should also have non-opioid options maximized first, meaning that medications like ibuprofen or acetaminophen should really be ideally optimized because they can be exceptionally effective at treating pain before we even think about prescribing an opioid to a young person. And then it's important when we prescribe opioids to screen for substance use and mental health conditions, to ask about a family history of addiction, which might put a young person at risk, to prescribe a short-acting opioid at the lowest effective dose for the shortest duration needed. Typically 3 days or fewer is enough, sort of as I was just saying in that last slide. And then to talk to families about the risk when we prescribe opioids and counsel them to lock up medications, to do pill counts so that they know how many pills are in the bottle and make sure that none go missing, and to directly administer the opioid to the teenager. So just some quick tips on how we can minimize the potential harm that we as physicians do when we prescribe opioids, which are still a mainstay of medical practice and can be very effective at treating pain. And I want to highlight now as we pivot to talking about addiction in teens, I want to talk about the ways in which our healthcare system is probably falling short when it comes to identifying and treating teens with opioid addiction. And this is really going to be sort of the basis for the rest of the talk today. Now, these data are from a US context where we have a little bit more information on the true prevalence of opioid use disorder in young people. But it turns out the overall prevalence of opioid addiction in young people is probably on the order of about 1% in the United States. It varies from place to place. Similar to Canada, there are places where likely the rate of opioid addiction in young people is higher, and then places where the rates of opioid addiction are likely lower. But overall in the US, it's about 1%. And I'd venture to say it's probably comparable in Canada too. If you ask the question though, of all those youth that are out there living with opioid addiction, how many actually get recognized by a physician? The truth is only a minority of them actually get diagnosed with opioid use disorder. And then of those that are diagnosed, even fewer actually receive any treatment whatsoever. Of those who get treatment, even smaller amounts actually get started on an evidence-based medication for the treatment of opioid use disorder, and I'll talk about those in a moment. And even fewer actually stay on medication and in treatment for a month, and far fewer altogether stay in treatment for 6 months. So the bottom line is, we as a healthcare system do a really sort of terrible job generally of identifying young people who are struggling with opioid addiction, getting them connected to evidence-based treatment, and then keeping them in treatment for addiction, which is a chronic and relapsing condition where really engaging young people in the long term is what's needed. And in the US context, if you look at disparities by race and ethnicity, it turns out that for Black and Hispanic youth, we are respectively our systems come up short in providing care that is centered for these young people, and that they stay in. We're not meeting them where they are. So Black and Hispanic youth in the US respectively are 65% and 74% less likely to receive any treatment for opioid addiction, and 32% and 58% less likely respectively to be retained in treatment in the short term. And so I would venture to guess, we shouldn't overgeneralize here, but I would venture to guess that there are probably some racial and ethnic disparities in the Canadian context too. Just knowing that our health systems sometimes fall short in delivering care that is equitable for youth of all different backgrounds. And yet there's an enormous opportunity here. And this is a quote that one of my patients, Aitan, asked me to share and has given me permission to share. What they wanted to share is that it's very powerful to get addiction treatment. What they said is that receiving addiction treatment in a primary care setting meant that I not only was able to access recovery, but also build a foundation for a healthy life. Coming into treatment, I had a multitude of medical needs that had been left unmet while I was in active addiction, from vaccines to chronic medical conditions to gender-affirming care. Together, my physician and I were able to address all of this in a place where I felt supported and safe. I was seen as a whole person, and because of that, treatment not only saved my life, but helped me thrive in it as well. And so I just want to highlight that, the ways in which we bring treatment into our medical settings really unleash a powerful opportunity for us to make a difference and impact, not just on the addiction of a young person, but their general health and well-being. So what are some things that we can all do, regardless of whether we are a pediatrician like I am, or a general practicing clinician, or a psychiatrist, or a nurse, or a social worker, or a psychologist, or even a nutritionist who might be working with young people, or someone working in a school setting? No matter where we are, there are things that we can do and systems that we can implement that will help to have an impact on young people. And so I want to highlight some key possible steps here. First, we can all screen for substance use and refer young people for treatment. 2, we can all talk to young people about overdose prevention and harm reduction. And then 3, we should do this as a society, not just as healthcare practitioners. We should change the language of addiction to reduce the stigma that young people and their families experience when it comes to living and existing in our healthcare systems. So what we do here is we implemented universal screening for substance use for all teens who come to our primary care practice. And increasingly, this screening is happening in other settings too, including mental health settings when our patients go and meet with a mental health provider. This screening happens in schools in many settings. In fact, our state of Massachusetts implemented universal substance use screening across our schools for high school students a few years ago. But the screener that we use or that many centers use, we actually use a slight variation on this, but it's very similar to this, the screening debrief intervention tool. And this has a lot of evidence behind it. It's a tool that's freely available. I've listed the website down below as well as a reference for it. Screening debrief intervention, or S2BI, asks a very basic question. It says, in the past year, how many times have you used tobacco, alcohol, or cannabis? And the question is asked in this very intentional way. It asks, in the past year, because we want to get at recent use, not use that may have happened in the past. And how many times have you used? So it actually asks the question, how many times, rather than have you ever used? And that's important because it actually increases the sensitivity of the question, right? If you're a young person, it's sort of harder to say, it's easier to say no immediately. That's a more natural thing that you might say if you wanted to sort of hide the truth. It's harder to go out of your way to say, oh, zero, which is the way you would answer it if you hadn't used any substances. And then depending on the frequency of these substances, of substance use, you can do different things with this information, which I'll show you in a sec. But if a young person has used any of these substances, you then want to go on and ask about other substances, including prescription drugs, including fentanyl, for example, or other things that young people might use. Now, I have to say, this screener was developed in the early 2010s, and the epidemic of teen drug use has really sort of evolved since then. And so when I ask these questions, I actually no longer ask about tobacco, I ask about vaping, and I ask about nicotine. And because of fentanyl and counterfeit pills, I'll specifically ask about fentanyl and counterfeit pills when I ask these questions. And so I think it's okay to adapt these questions, but I do think this question stem of, in the past year, how many times have you used, is a good prompt and a good lead into asking about each of these substances. And the reason that the frequency of substance use matters is that it actually maps to the likelihood that a young person has a true substance use disorder, such that a young person who in the past year hasn't used substances at all, or has only used once or twice, that's strongly correlated with them not having a substance use disorder at all. A young person who's using a substance like cannabis or alcohol or nicotine at least monthly is likely to have a mild to moderate substance use disorder. And a young person who's using a substance at least weekly, and I know that we all have patients who tell us, I use cannabis every day, I don't have a problem, I can stop anytime. It turns out that if you dive deeper and do a more complete clinical interview with them, there are probably lots of different ways in which their substance use is adversely affecting their life. And so therefore, weekly or more frequent use of a substance is strongly associated actually with them having a severe substance use disorder, whether they're able to acknowledge that or not. But the key here is really to ask these questions in the first place, and then you need to know what to do. So, we can all counsel youth, and we should all give youth brief advice to cut back or decrease their substance use, because that's important. But certainly some youth, especially youth who are using opioids, may need more intensive services. And there, it's really important to get to know the various treatment programs that are in your area. Unfortunately, Healthland BC does keep a directory of various mental health and addiction services that is searchable and that you can use to identify some of the treatment programs that might be available in your area. I know this is tricky. I know it's easier said than done to go to a website than it is to actually find an available bed and an opening in a program. But I think the first step is at least getting sort of aware of the programs that are in your area so that you can start to build relationships with them and potentially be able to refer patients who may need these services. And some of you may be parts of some programs that are providing these services. The other thing that I want to make sure is really sort of driven home is that young people should have access to medications for opioid use disorder. So there are 3 approved medications for opioid use disorder that are available in the US context. It's a little bit different in Canada in that the third of these in its injection formulation is not widely available in Canada at this time. But the first medication is buprenorphine. It sometimes goes by the brand name Suboxone. The second medication is methadone, which here in the United States is much more restricted in terms of access, but in Canada is much more available. And then naltrexone, which is an opioid blocker that blocks the ability of a person to experience the euphoria of using opioids. In the US context, we have naltrexone available as a long-acting injectable medication that is less readily available elsewhere in the world. And the reason that medications, even though they're commonly overlooked and not often made available to young people, the reason that they're really important is that clinical trial data show that these medications treat withdrawal symptoms and address cravings for opioids. They result in better retention in addiction care. They're recommended by major pediatric and adolescent medicine and addiction medicine professional societies across the world. And it's important to know that they are typically offered alongside behavioral health services for young people, but that's not necessarily required. If there's a young person who wants to get medication but doesn't want to engage in counseling or hasn't been following up with their counseling or therapy, that's okay, because the medications impart life-saving capabilities even when a young person is not engaged in therapy. Ideally, I think young people have a lot going on. They often have multiple diagnoses. They may have depression, anxiety, or other conditions that would benefit from behavioral health services, but strictly speaking, it should not be required for young people to engage in treatment with a medication for them. And for those of you who might be prescribers who are just interested in learning more about how to prescribe these medications, there's great training available online. There's a US-based training program called pcssnow.org, and their training materials are available to everybody across the world. And in my opinion, I think they're probably the highest quality, most reliable teaching opportunities that are available. And they have some youth-focused educational offerings as well. We also need to talk to young people about how to prevent overdose. So we have to remember that sometimes young people are going to continue to use substances, including fentanyl, when they are engaged in our services. And we need to be prepared and able to operate in that gray zone where, even though we make the recommendation that they cut back or quit substances, that we help to empower them to stay safe while they do. And so simple things that we can counsel all youth include to be aware of counterfeit pills and be aware of the fact that the heroin supply is often tainted with fentanyl, that other types of drugs like cocaine are sometimes tainted with fentanyl as well. And people should be aware that this is everywhere. And because of this, young people should be counseled not to use substances alone. They need to make sure that there's someone around to address an overdose if one occurs. They should start with a little bit of a substance that they're planning to use to assess its effect. So if they're about to use a counterfeit pill or a pill that they don't know to be counterfeit, start with just a quarter of the pill and see how they feel to understand the potency of that product. They should avoid polysubstance use. They should avoid mixing opioids and fentanyl with substances like benzodiazepines and alcohol, which are substances that increase the risk of overdose. They should be aware that they need to call 911 in the event of overdose, and they should carry naloxone around with them. And that's, of course, what's pictured here in the bottom figure. In the Canadian and British Columbia context, young people should be able to go into pharmacies and request a Narcan or naloxone rescue kit for them to take home with them and carry with them so that they can respond to overdoses and help rescue a friend and make sure the friend has it if they themselves are using. And then, of course, there are other aspects of harm reduction. Even when youth aren't ready or able to stop their substance use, in addition to helping them prevent overdose, we can offer them HIV testing and pre-exposure prophylaxis to prevent HIV. We can offer them hepatitis C testing and treatment. We can offer them syringe exchange and education on safe injection. And in particular, in the context in British Columbia, you all have been absolute leaders in this work that the rest of the world, especially us here in Boston, we all look to for your experience and expertise. And so just remember that you have these services available to you, and they're much more robust than in many other places across the globe. And you know, the idea behind these services is, first of all, they don't somehow lead young people to use more substances or to not quit when they might have otherwise been able to. They're not enabling substance use, as some people would argue. What they're actually doing is that they're keeping young people safe and building trust with you as someone that they can then turn to with their health, safety, and well-being, and that they can turn to when they are ready and interested in engaging in treatment. They know exactly who the person is that they trust. The other thing worth bringing up, and I'm not sure how readily these are available in British Columbia. Perhaps you all can teach me today. Fentanyl test strips are increasingly widely available here in the United States. And I'm looking down because I had some under my desk that I was going to show you, but I realized I walked them over to my clinic the other day. Fentanyl test strips are these small test strips that, in the era of COVID and COVID testing, probably many of you are increasingly comfortable with dipping, putting wet stuff on a stick and then looking for one or two lines. What you do with a fentanyl test strip is you take a small amount of a drug that a young person is planning to use. So they could take a little piece of a pill that they're planning on using, add it to a half teaspoon of water and kind of mix it all together, and then dip the waxy end of this fentanyl test strip into that water for 15 seconds, remove it, and then place it on a dry surface, a flat surface for 2 minutes, and then look for 1 line versus 2 lines. It's just like a COVID test or a pregnancy test. 1 line means no fentanyl, and you just have the control strip that's lighting up. And then 2 lines means there's fentanyl present in that drug. And then the last thing I want to impart is that we can do a lot to improve in our own healthcare environments to battle stigma that young people and their families and just people in general experience when they're living with addiction. And I want to highlight a recent policy statement that we put together for the American Academy of Pediatrics that just highlights some problematic terms that you've probably seen in the media. You may have seen in healthcare environments that people use to talk about young people with substance use disorders. And I just want to highlight that it's so important for us to be talking in person first language, to start with, in the same way we don't say that that's a 16-year-old diabetic. Instead, we say that's a 16-year-old boy with diabetes. We talk about people first as a person with a substance use disorder. And there's some other problematic terms that I've listed here too that are falling sort of out of favor that can be stigmatizing in various ways. And with that, I will wrap up. I just want to highlight some changes you might wish to make in your own practice to summarize some of the things that we've talked about. Remember to screen for substance use and addiction using a validated tool. I've listed some here. S2BI is the one that I presented and is freely available online. In your own practice and or through referral, consider delivering evidence-based care, including addiction treatment, overdose prevention, and harm reduction. And then we all need to use non-stigmatizing language when we're working with youth and families who are affected by substance use. And I will stop there. Thank you so much.
That was great. Thank you, Dr. Hadland. So I will now open the floor to all of our participants. Feel free to write any questions you may have in the chat. I'll be looking at the chat. Anas, you can go ahead if you have a question. I'm also welcome to have you unmute yourselves. It might be better for participation and make me feel like we're more in person. So go ahead, please.
Thank you so much for your talk. As always, it's fantastic, and I'm always learning. I'm an emergency physician, and a lot of the youth that we meet in the emergency department, it's their first interaction with the healthcare system after an overdose, and they don't have lots of connections, and we don't know much about them. So we're working to develop partnerships with our colleagues with adolescent medicine and community partners. I'd love to hear about, in your experience in Massachusetts and other places, what is the journey like for a youth who presents after an overdose in the emergency department when they're 15, 16 years old? I know that there's different legislations and different realities, but I'm just curious to learn about your experience.
Yeah, it's a great question. And I think, unfortunately, the journey for most young people is to bounce around a lot. If a young person has diabetes, it's often really clear where to send them. But when a young person has a substance use disorder, families really kind of get lost in the churn. It's really easy to have a lot of false starts, to call treatment programs that have wait lists or, require private pay, or may not have a model that sort of is of the right philosophical bent for the family. And so there's a lot of false starts in this work. And in my own experience, I often find that a young person has often been to multiple different treatment programs before they ever make it to me. And what that also means is that because many addiction treatment programs are not using evidence-based techniques, they're often not receiving medications for addiction treatment, or they're being presented with abstinence-only options, and they're not being taught how to keep themselves safe from overdose, or not being taught certain harm reduction approaches that are pretty straightforward. And many adult drug users know, but many young people who use drugs have never sort of encountered or never gotten that messaging or public health information before. And so it's an important opportunity for us to be ready, poised, and able to support young people, even if it just means talking to them about overdose prevention, or even if it just means talking to them about harm reduction, knowing that the systems are tough and the journey is long, and that there are a lot of these false starts, but there are these moments where we can nonetheless truly connect. And I guess I would say my one recommendation for everybody is, I think what young people are used to encountering in healthcare is that when they use drugs, people are not kind to them. That if you show up in a healthcare setting and you're intoxicated, or somebody learns from reading the medical record that you use drugs, you're often treated with hostility, or people are just not kind to you. And I think to the extent that you can just be endlessly compassionate and demonstrate kindness to young people, that's going to go a long way. And that might be a better intervention than almost anything else that we do as we try to help connect people to the services that they need.
Great, thank you. And if I'm allowed to have a follow-up, is there a place in your setting for involuntary care straight from the emergency department for youth who presents with a severe, substance use disorder?
For voluntary care?
Involuntary. So are there dispositions that, because that's a big struggle we have. We have very diverging views on that, and I would say that on a daily basis, every time we have this clinical scenario, we have those really tough conversations, and there's no right answer. And I'm just curious to see how that debate is taking form in your setting.
Yeah, it's interesting. In Massachusetts, we actually have had involuntary commitment of young adults. We can what's called section a young adult, meaning that a young adult who is perceived to be having such a severe problem with addiction that their life is at risk. We have a legal system that allows us to do what's called a Section 35, which means you can mandate that person go to treatment for their own good and well-being, is sort of what people will say. What's really interesting is that's something that a lot of families asked for in the state, but is actually in a lot of ways backfired. And there had been a lot of really high-profile cases in our setting where a young adult has been sort of required to go to treatment because a parent or a physician or some other person has sectioned them, has compelled them to treatment. And then that young person either is treated very poorly in the settings that, because we haven't done a good job of giving them good, compassionate settings to receive this care. In fact, the quality of these settings has been very low traditionally. So that's one big problem, is you got to make sure that if you're going to force someone to treatment, you got to make sure it's high quality evidence-based treatment. But the second piece is that there are a number of young people who they're forced into treatment. They don't really engage in the treatment because they're not there because they didn't choose to. They're not there because they chose to be there. They're there because they were forced to be there. And then when they leave, they're at exceptionally high risk for overdose and relapse again. And so there again have been some really high profile cases of young people forced into treatment, kept safe while they're there, but then as soon as they're released, had a really bad outcome. So it's really complicated. And I believe, and I don't have data to support this, but I believe, having watched this played out, that probably the best approach is to just work really hard to try to engage a young person in treatment, but to have them be a part of that decision to go into treatment.
Thank you so much. I share your view. Thank you.
And Elizabeth in the chat said, thank you for bringing up the point of the importance of kindness and compassion when youth encounter healthcare providers of any kind in any setting. I think that the key to start of any kind of forward path to health for youth is to know that there is somewhere that they won't be judged and where they can trust those with power. This kindness and compassion must be genuine for it to be effective, and youth can sniff out a fake from a mile away. So just reflecting what you've said. Open any other questions. Thank you for answering those, and thank you for those questions, Dr. Manuzzi.
And that's a great comment. I completely agree with what's in the chat.
I'll wait for some other questions to come up. I actually had one to kick things off as well. So I'm sure that you bring up the topic of OAT and medication for youth often with the youth. And I was wondering what are the answers of youth? Do they have any concerns as to maybe saying, I don't want to be on, like, I know the stigma of being on medication. I don't want to be on it for the rest of my life. There's also the question of, are their families encouraging of being on this medication? So what are the concerns that youth often come up to you and have when you're discussing this? And how do you walk that line and discuss those with them and with their families as well?
Yeah, all of the above. I think actually you did a really nice job of summarizing probably the key ones that I encounter. That whereas if you have a person who's been using heroin for 30, 40, 50 years, and they can't imagine once they go on methadone or buprenorphine, they can't imagine coming off the medication and probably conceptualize that they'll be on that medication for the rest of their life. It's very different when you're talking about a young person who might only have been using opioids for like a few months or a couple of years, right? And so there is this sort of like probably sweet spot or magical period of time that a young person should be on medications that isn't forever, because young people don't want to be on a medication forever. If they have high blood pressure, they don't want to be on high blood pressure medications for the rest of their life, right? But we have to do the research to figure out what that sweet spot looks like. And so for now, it's a very individually tailored approach. I would say there's just a lot of hesitation towards medications in general. Some of that comes from just a general distrust that many families have of medications, even when we're talking about depression or anxiety. There are some families who just say, like, I don't want my kid to go on a medication, right? And even though the data would suggest that medications are very effective, and it's our job to provide that counseling and help folks understand what the data show, many families will still just not want a medication because it's a medication. And then layered on this, there's a lot loaded with these medications that they'll hear stigmatizing statements out in the community like, oh, well, if you go on methadone, you're just treating one addiction with another, right? That
Right.
You're going on, you went from being on one opioid to being on another opioid. Yeah. And I always want to highlight that, the definition of addiction is not just use of a substance, but it's use of a substance and then having negative consequences from it and having loss of control over your substance use. And so the difference between a young person using fentanyl every day is that their lives are often chaotic. They might be, they have disrupted relationships. They're unable to go to school or to work. They may actually, in some cases, be homeless. There's all these ways in which substance use has really kind of created a chaotic life circumstance for them. But if they go on methadone or buprenorphine, those medications, even though they're opioids, treat them and make their lives more stable. And all of those problems resulting from chaotic substance use start to go away. And so that's how these medications are not another addiction. They're actually a treatment for addiction because they're making those negative consequences and that loss of control going away. So anyway, this is a lot of the reframing that we have to do in this work, I think.
Yeah. Thank you. I'm just waiting for any other questions. That's similar to what Dr. Azar, the keynote speaker earlier, was talking about. He gave a presentation with a patient who was put on medication and was able to stabilize the things that are surrounding his substance use, and he was able to get a job, and he's now, I think married. And so it was a wonderful story that also you're highlighting as well. I looked up, and I'm going to put in the chat the S2BI. So if folks want to take a look at that, I just put in the chat right there so people can look at it. I think it's a wonderful tool that I didn't know about. So there you go.
I have another question.
Yeah.
So we are looking at implementing similar screening tools in the emergency department, and some of the questions from the providers is how let's say youth comes in for knee injury or something else, and then we start asking those questions. How safe can we make this conversation? And then wouldn't it be worse to open a door without having the expertise and the immediate follow-up team ready to help. It's almost like we're opening people's histories or traumas and then say, well, go on this website and register. I think those are some of the pushback that we are getting. So just want to see what's your experience to make those screening tools actually impactful and meaningful.
Yeah, no, I think it's a good point. And this is a thing we sort of always hear about in medicine, right? You shouldn't screen for something unless you have a response to it. That is true. I don't want to discount that. But I also think, like, isn't it worse to not know any of this information about a young person as a healthcare provider? And so I think there are ways in which, even when we screen, and even if we don't deliver the effective intervention in that moment, we might be better equipped the next time a young person comes into a healthcare environment to be able to take this on. And so I think actually, when we have this information, it's better than not having it at all, even if we don't have total confidence in our ability to link that person to treatment. And I think that there are some really simple and straightforward things that we can all do, if nothing else. One is just to talk openly with young people about substances after they screen positive and demonstrate that, like, you're not going to get in trouble in a healthcare environment, that what we really want to do is, like, put your safety and your health and your well-being first and have open dialogue about this. So creating a welcoming, affirming place to talk about it. But then even just some of those pointers that I put up about how you can help arm a young person with information to keep them safe so they don't overdose, or so that they can respond to their friend's overdose. Like, that's important in and of itself, even if that young person isn't getting connected to treatment. So I think even when the system is not perfect, the information is still helpful to know, and that we can still do something with it that might be more impactful than we realize. The question about, I think maybe we were getting at with your first question is like documentation of this information in the medical record, and like, do parents have access to that information, and could there be a breach of confidentiality where a young person's information about substance use is kind of leaked to their parents? That is an important thing to think about. And so it's worthwhile just understanding in your own system, when you document this stuff in the medical record, who gets access and who can look at it. Because in our own setting, we're actually able to label that as confidential and make it so that parents don't have routine access to it. But I know my colleagues in other settings don't have that luxury. And so it just is worth, like, understanding and playing out what that looks like in your context.
Great, thank you.
There's a question by Grace in the chat here that says, are there any interventions involving cannabis use for supporting youth with addiction? Example, in the context of opioid substitution.
Mm-hmm. Yeah, that's a really good question. So the question is around, just to be clear here, like helping support young people who are using a lot of cannabis, maybe in the setting of an opioid use disorder. Is that right?
That's my understanding as well. Grace, if that was not what you were meaning, please let us know. Yes, she says yes.
Okay, great. Perfect. Thank you. I just want to make sure I answer this the right way. I will say, we all care for a lot of young people who are using a lot of cannabis. I know it's a big, here in Massachusetts, we have a pretty high prevalence of use. I know what it's like in British Columbia. As I said before, I was once a teenager in British Columbia. So I knew what it was like in the 90s too. So opioid use is really, or cannabis use is really common in this context. I follow the young person's guide on this because I think this is a place where you can use really youth-centered approaches. It is probably the case that it is best for us to treat an opioid use disorder and a cannabis use disorder at the same time. So try to encourage young people to cut back on their use of both. But I have a lot of patients who tell me, I can't give up one without the other. So if I'm going to be giving up if I'm going to be giving up opioids, I'm going to need cannabis to kind of lean on during that time. And I think that's what you're getting at with this idea of cannabis substitution. And so I think the thing that we all need to do is be comfortable as practitioners understanding that we give guidance and we make recommendations for youth, but they may ultimately choose to go about this their own way. And we don't turn our backs on them when they do that. We try to work with them and meet them where they are. There are some sorta okay treatments for treatment of cannabis use disorder. So if you imagine that you got a young person off of opioids and then they were using cannabis every day and you wanted to help them cut back on that, good old-fashioned motivational interviewing is reasonably supportive for young people to cut back on their cannabis use. There's some other medications. N-acetylcysteine given at a dose of 1,200 milligrams twice daily is something we'll use sometimes in our clinical practice to decrease cravings for cannabis, but it's not super effective. And so this is kind of a tough place in the work where, cannabis probably is not going to kill our patients, very fortunately, but it can also be really difficult to help young people get off of it. But we just keep trying and we keep working at it.
Great, thank you. Grace, I hope that answered your question, and thank you for the question.
And I'll say, by the way, as an aside, it's the hardest thing of what I do. I actually am much more successful at treating opioid use disorder, nicotine use disorder, alcohol use disorder than I am at being able to successfully treat cannabis use disorder. It's the hardest.
Because of the sheer quantity, or just because of like what kind of what's the reason for that?
I think it's a lot. It's there's normalization of cannabis use. There's the idea that it's green and natural and not nearly as bad as the other stuff. Right. There's the ways in which cannabis just makes you feel better, particularly if you're struggling with anxiety or mood disorders. In the short term, it does make you feel a little bit better, and it's hard to sort of see past that.
Yeah.
So it's just tough.
Yeah, for sure. So there, Courtney, I see that you've raised your hand. Please go ahead and ask a question if you have one.
Hey, Courtney.
Hi. Yeah, just as a follow-up to that question, something we've heard here in the BC context a lot more recently is youth asking us to recognize cannabis as a harm reduction tool or treatment. Mm-hmm. So like officially asking, instead of like, for example, going like OET, can we use cannabis? And we want this recognized because that's what we're doing anyways. And we want this recognized in a medical setting. Is there any like research to back that up, or what are your thoughts on that?
Yeah, it's a great question. We do need more research. And Courtney, out of curiosity, where are you right now?
Oh, I'm in Vancouver.
Okay, great. Say hi for me. I just saw your background there and was curious. Yeah, I don't routinely recommend cannabis as part of someone's treatment plan. I really do go for the gold standard medications that have a strong evidence base behind them. There is evidence to suggest that cannabis is beneficial for patients, and they'll tell us this, that like I feel better as I'm cutting back or stopping my opioid use, it feels better to use cannabis. I get it. I hear that, and so I work with youth when they really believe that this is going to be part of it, but I try to make sure that I'm nonetheless recommending the evidence-based medications, and making the recommendation that like cannabis is still not sort of the be-all solution here, and we shouldn't rely too heavily on it. I will say there is a harm reduction piece when it comes to cannabis too, that a lot of young people are using enormously high levels of THC because they might be dabbing or vaping THC. And, vaping THC cartridges just comes with like sky high THC exposure. And so another harm reduction measure that I think is helpful for young people to know and hear about is that it's much harder to stop or cut back on your cannabis use if you're vaping THC because of the really high levels of THC you get exposed to, and much easier if you're using edibles where the dose is a little bit more understandable and controllable, much easier if you're using joints, which are just sort of like lower THC concentrates. And so this is another place where I, as a practitioner, operate in a gray zone where one of my priorities is actually try to get teens to stop using the really high potency THC exposure modes of delivery like vaping, and try to use some of the lower concentration delivery methods.
Interesting, thank you. And I was just a bit surprised, like say, like for harm reduction, that you would say that you would suggest instead to use like joints instead of doing vaping, just because of that THC concentration. Because I think it was often the opposite that I think we've heard is to vape because it's potentially better for your lungs and whatnot. So that's changed.
Well, it's interesting. I mean, I know the idea of burning something and putting it into your lungs is uncomfortable for us as practitioners because that's smoke. The data have really not been as compelling as you would think for the harms of smoking cannabis. It's the data are very different from smoking tobacco, where there are clear long-term harms. The data on smoking cannabis is a little bit murkier and not nearly as like clearly bad. I mean, to just say it out loud, if I am actually like helping a young person to come down off of their THC that they might be vaping, I have in some cases helped them use edibles as a way to come down, because edibles sort of come with a more controllable, understandable dose. They have a long acting period of time. They're sort of like giving methadone in some ways to somebody who has been using fentanyl. So instead of like the ups and downs of fentanyl, you give methadone. There's sort of a way in which THC edibles may sort of provide a similar benefit, but that is not evidence-based practice. So I have to sort of disclose that out loud, but it is a thing I've done before.
Great, thank you so much.
Thank you, Courtney. So unfortunately that went by quick. That brings us to the hour. So Dr. Hadland, I want to thank you and all the participants for coming online. I'm not sure if you had a few words that you wanted to say right before we left, but if you do, now would be the time.
No, thank you so much for this little mental health journey home, and be kind to young people. Even when it sometimes feels hard, even when it's late at night, even when, we all know young people can sometimes be tricky to work with, but be kind, because I think that it goes much further than we all realize sometimes.
Thank you, Dr. Hadland. And so I, just for everyone else, I've posted a link to Dr. Hadland's paper, which I had a lot of the ideas that you've mentioned today. If you want to read up on that or share that. So that's in the chat. But again, thank you everyone. And I hope you enjoy the rest of the conference.